All right, so today we're going to talk about tobacco cessation from chapter 37 in your book. So here are our objectives that we are going to go over in this PowerPoint. Okay, so we're going to talk about the history of tobacco a little bit here. As you can see on this picture to your right, it's showing soldiers from World War II in the hospital, and the nurses are handing out cigarettes to all the soldiers. We also know that cigarettes were also issued to soldiers during World War II as well. But if you look at this picture here on the left, dentists also used to recommend cigarettes to their patients, right? During that time, we thought that tobacco was good for you. So here it says dentists say smoke Viceroys, right? The filter removes the smoke. It'll never stain your teeth. But then if you look at the bottom, it says no filter can reverse all nicotine and tars, and nor does Viceroy make this claim. Yet they're obviously making that claim in their advertising to try and get people to buy their product. It wasn't until 1964, when the first Surgeon General's report on smoking and health came out. Luther K. Terry was the Surgeon General at the time, and here is what he had to say about this report.
The strongest relationship between cigarette smoking and health was in the field of lung cancer. There is a very strong relationship and probably a causal relationship between heart disease and cigarette smoking.
Okay, so even in here, they said there's a very strong relationship between lung cancer and smoking. They didn't come out and say lung smoking causes lung cancer because this was very early on, and so they didn't have all the studies to prove that yet. But we, over the years since 1964, we've done lots of research and study and have shown that it does cause lung cancer and other things. So if we look back at 1964 when this Surgeon General report came out, we see in red, that's men, 51.9% of all men in the United States used cigarettes and 33.9% of women. So if we do the general population, it's at 42.4% of the general population in the United States that use cigarettes during that time. So we've done lots of things since then. And now, as of 2020, the general population was at 12.5%. So throughout the years, first we had the Surgeon General report on smoking and health. Then 1973, Arizona is the first state to restrict smoking in some public places. In 1988, the Surgeon General's report concludes nicotine is addictive. In 1990, Congress makes domestic airline flights smoke-free. And 2009, they had the biggest federal tobacco tax in U.S. history. And public health, putting taxes on tobacco is a known public health policy, because as you increase the cost of tobacco, then people aren't as likely to go and purchase the product. Also, the tobacco tax is used for many different things. In each state, there's a quit line that's usually funded by the tobacco tax. Also, other things can be funded by the tobacco tax, like social programs and education. And then in 2019, the federal minimum age was raised from 18 to 21. And this is really important, especially when it comes to high school students and vaping, because there are a lot of high school students who are 18 And so they are able to purchase tobacco products and give it to their friends or sell it to their peers. And so by raising the age to 21, that helped eliminate a lot of the tobacco products that were in the high schools. So, why that's important is because of all adult smokers today, um, 9 out of 10 started before the age of 18, and 98% started by the age of 26. We know that our brain is still developing up until the age of 25. So if you're using these products before the age of 25, you're more likely to become addicted because it changes the chemistry of your brain. So if you think about it, if you pick up a cigarette after the age of 26, the likelihood of you being a lifelong user is drastically reduced. And the cigarette companies, tobacco companies know this. So they want to try and reach people at a younger age. For cigarettes, it was most common age to start was age 12. For e-cigarettes and vaping, it's much lower. It's age 9 or 10. They were having issues in elementary schools with finding kids with vapes. And 81% of youth users cited the appeal was the flavors as the primary reason. So if you look in your textbook for box 37.1, figure 37.1, and table 37.1 is going to go over your systemic health effects. Um, Tobacco causes approximately 6 million deaths worldwide each year. In the United States, it's 480,000 deaths estimated each year from cigarettes. Tobacco is one of the only legal consumer products in the US today that if you use as intended, it will kill you. But your death certificates do not state tobacco use. What you find on the certificates are oral cancer, lung cancer, breast cancer, emphysema, COPD, heart attack, coronary thrombosis, heart failure, cardiac arrhythmia, pneumonia, and other diseases. Then if we look at other behavioral um, causes of death per year and compare them to tobacco, we see tobacco in the United States has 480,000 deaths per year. And then if you combine alcohol, illicit drugs, suicide, car accidents, homicides, AIDS, and HIV and fires, it is only about half the amount of deaths per year as tobacco. And then when we look at tobacco and pregnancy, it can cause miscarriage, preterm births, low birth weight babies, infants with cleft palate and lip, growth retardation, tooth malformation, which is important in our work, and sudden infant death syndrome. And we looked at that chart to see how many adults in the general population are smoking, and we're down to 12%. And of that 12%, who are the people who are most likely to use the tobacco products? So here shows that tobacco use by those with mental health. So people who use illicit drugs use tobacco, 98% of them use tobacco products. For alcohol use, 93%. Schizophrenia, 90% of those with schizophrenia use cigarettes. Major depression, 80%. Bipolar, 70%. Anxiety disorders, 60%. PTSD, 60%. And ADHD, 42%. So when we look at this, most of those people in those categories are also taking medications, right? Tobacco use does reduce the effectiveness of those medications. So when we are talking to patients and trying to help them quit using their cigarettes, we need to have them work with their doctor because they may need to make some adjustments to those medications. especially if they're taking antipsychotics, antidepressants, mood stabilizers, anxiolytics, and other medications. They're going to start working better when they get off the tobacco. And so that could cause some issues, and they may need some adjustments to their dosages with their doctor as they begin to reduce their cigarette use. So, nicotine in 1994 was classified as an addictive drug. It does act on the receptors in your central and peripheral nervous system, and that's how it results in addiction. The absorption of nicotine does depend on the pH of the environment. So, tobacco companies um, match the pH of their products with the pH of your mouth, of your oral cavity, so that that nicotine is able to be absorbed quickly. And then it is a powerful poison and pesticide. So, nicotine is a naturally occurring chemical in the tobacco plant and other plants, and it's to help as a natural pesticide against insects from eating the plant. But this also makes it a very powerful poison. And in recent years, poison control calls for nicotine overdose has increased. So, or for nicotine poisoning. So before, more than half those calls involved young children under the age of 5, and poisoning from traditional cigarettes, it was generally due from young children or pets eating like cigarette filters or eating cigarettes. But with recently with vapes and the liquid, you can get nicotine poisoning due to ingestion, inhalation, or absorption through the skin or the eyes. And these liquids, they smell good, they taste good, they have lots of flavors. So it's more enticing for these little children and toddlers and pets to get into the liquid and ingest it. So mild nicotine poisoning, it can cause nausea, vomiting, dizziness, tremors, sweating, tachycardia, and high blood pressure. And severe poisoning can be life-threatening and lead to seizures, which some seizures can begin in as little as 20 to 30 minutes after the nicotine poisoning. So most people who use nicotine or tobacco products is for anxiety, right? So that's why a lot of people with behavioral health issues will use it to try and help with their anxiety. However, the signs of withdrawals versus anxiety are very similar. So somebody could be having withdrawal symptoms of frustration, restlessness, difficulty concentrating, irritability, anger, insomnia, depressed mood, increased appetite. And then they take a hit on their cigarette and those symptoms go away. So you can see in the anxiety side, many of those symptoms are the same as withdrawal. So, we can question, is the cigarette actually helping with anxiety, or is it helping reduce their withdrawal symptoms? So, nicotine addiction, you want to look at your table in the book 37.3. It has reinforcing effects, which causes the brain to release chemicals like dopamine, norepinephrine, acetylcholine, vasopressin, serotonin, and beta endorphins. It has tolerance, so the longer you use it, the more nicotine you need to achieve the same effect. And then it also has physical dependence. So your brain function becomes disturbed and it causes those withdrawal symptoms and addiction. So it's chronic relapsing brain disorder is what nicotine addiction is. So an example of this is my husband had a coworker that used chewing tobacco. And he asked him one day, like, why do you do that? It's such a disgusting habit. You're always spitting and you've got all these gross juices in your mouth and tars. And he said that he started when he was a teenager. And he said that first time that you put it in your mouth, you get it, uh, this euphoric feeling. That's the best feeling he's ever had. And every time that you put the chewing tobacco in after that, you're trying to get that same feeling that you had the first time you did it, but you never do. But you just keep trying. So this is showing those reinforcing effects, tolerance, and physical dependence, right? The reinforcing fat effects, first time he put it in, he got that dopamine, norepinephrine rush, right? Makes you feel really good. Dopamine makes you feel really good. Then tolerance. He has to keep using it and putting more and more to try and get that same effect he had that first time that he used it, but he never gets that same effect. And that's that tolerance building up. And then the physical dependence is your brain starts to um, crave it and want it and it gets used to it and it likes that dopamine. And so then when you don't have it, it starts those withdrawal symptoms, and that's where you get the addiction. So, psychologic, it provides a sense of comfort, security, or entertainment. These are all reasons why people continue to use cigarettes. Behavioral, so it's associated with pleasure or other behaviors. Usually, they have it with alcohol or coffee while they're eating. Like first thing in the morning, they'll get up, have a cup of coffee and a cigarette. And that will start to trigger, for those of you who are in my psychology class, the same as the Pavlov's dogs, right? You hear the bell, and then that triggers that salivation that they're going to eat. So it's the same with cigarette. You have that taste of coffee first thing in the morning, and that triggers that bell. Oh, I want my cigarette. Okay, so those cues or stimuli, they generate that strong urge to use that tobacco. So a lot of people who drink alcohol while smoking, if they are going to try and quit, a lot of times they have to also quit using alcohol because anytime they have a drink or a beer or whatever, then that's going to trigger to them a craving for that cigarette because they usually do it together. There's also a sensory thing to it, that oral gratification. A lot of people like to have something in their mouth or that hand to mouth action. And then social cultural. So peer pressure, family influence, social networking. Um, 3 out of my 4 brothers smoke. And one of them, he worked in a warehouse, and everybody would just go on smoke breaks together. And if you didn't smoke and you didn't go on these smoke breaks, then you weren't, making friends, or you weren't part of the group there. My other brother started when he joined the military. I don't think he does it now that he's out of the military. It was just something that you did as part of your unit, to be a part of the group. And there's a lot of influence in that. Also, if somebody's going to try and quit and everybody around them is smoking, it's going to be very, very difficult for them to quit unless they have a supportive social network around them. So some of the oral health effects, you can also refer to your book on figures 37.2, 37.4, and 37.5 in your textbook. So oral effects, here's some of the things that we're going to be talking about. So tobacco stain, so tobacco tars and chemicals, they cause discoloration, staining of the tooth structure. It can stain dentures and non-metallical restorations as well. And as the tobacco use continues, complete removal of that stain can become impossible, especially if they have a lot of Donald disease and recession, and that stain gets embedded into the cementum, it is really difficult, if not impossible, to remove. So here we have necrotizing periodontal disease. So, um, smoking is one of the main factors associated with this. Other factors can include poor oral hygiene and emotional stress. And one study reported that smoking contributed to 98 out of 100 cases of necrotizing periodontal disease. So when you guys learn about this, necrotizing periodontal disease is also called trench mouth, and it was very common during World War II with the soldiers. And that's because they were malnutritioned. They had poor oral hygiene when they're just out in the trenches. They were extremely stressed, and many of them smoked. I mean, they were given cigarettes. They were issued cigarettes in their packages, right? So all of those things contributed to necrotizing periodontal disease. Here we have black hairy tongue. It is seen almost exclusively in heavy smokers. And what this is it's chemicals from the tobacco coat the tongue and don't let the cells on the papilla slough off normally, so they become thick and elongated papilla. It can cause a burning sensation on the tongue, halitosis, and it can sometimes trigger a gag reflex in your patient. And for you, if you see it, because it looks really gross, right? But when you brush the tongue and they quit using the tobacco, it will go back to normal. So teaching your patient how to use tongue scrapers and how to clean their tongue properly can help reduce this. And then obviously when they stop using their tobacco, all those chemicals won't coat the tongue, and so they won't get this anymore.
Nasty side effects like black hairy tongue. Just another way dipping does you dirty.
I just think that's a silly video. I like it. All right, so dental caries, especially in chewing tobacco, there's a lot of sugar. So it can be anywhere from 2 to 35%, and they're constantly putting in more chewing tobacco. So once that flavor leaves, kind of like with gum, right? You spit it out and you put in a new one. And so they're just constantly bathing their teeth in that sugar. A study did show that chewing tobacco and dental caries, they were at a 4 times greater risk of caries when they use chewing tobacco. But also children who are exposed to secondhand smoke are 2 times as likely to have dental caries. Here is tobacco melanosis. So it can be mistaken for normal pigmentation. Um, It does occur in about 5 to 10% of smokers, and it's probably dose and heat related. The condition is reversible when smoking is discontinued, and there's no clinically significant known risk. It is not known to occur in people who use chewing tobacco. So that's why it is assumed to be heat related, because those who use chewing tobacco don't get this. Tooth abrasion. This usually happens from those who use chewing tobacco because there is a lot of grittiness in chewing tobacco, and that can float around in their mouth while they're eating and speaking in their saliva, and it just wears down the enamel. Implant failure is linked to smoking. Um, Tobacco can affect the cells that are involved in wound healing, vasoconstriction, and decrease in tissue perfusion. It has a reduced alveolar blood supply, so meaning that it reduces the blood supply that goes to the bone. And we need bone formation around that implant to make that implant stable. So bone formation is compromised, and that's mainly from the nicotine exposure. In nicotine stomatitis, it's most often in pipe and cigar smokers. It is thought to be also related to the heat because there is a lot of heat in pipe and cigar smoking. It does not have significant pre-malignant potential, but it can turn into oral cancer, so it's just something that you want to watch. And if you see any significant changes, then you want to have refer them for a biopsy. Local recession can happen due to chewing tobacco. They usually put it in the same spot, and that can wear away the gums in that area. Same with snuff keratosis. That's usually from chewing tobacco being placed in the same spot continuously. It can be precancerous and is more prone for malignant transformation, so you shouldn't neglect it. Biopsy should be performed if there's any evidence of erythema or ulcerations. You want to speak with your dentist, but some will have the patient check it by biopsy at least once a year. Um, 98% of the patients, the oral mucosa will resume back to normal within 2 to 6 weeks after they stop using the chewing tobacco. You can also encourage your patient to move the chewing tobacco around into different areas of the mouth so that it's not in the same spot forming that keratosis area. Here you have erythroplakia. Um, it is known to have precancerous potential due to the numerous cases that were diagnosed that progressed to carcinoma. Biopsy in this is essential. It's a bright red velvety plaque that can't be characterized as any other condition, and it's asymptomatic, meaning that it doesn't cause the patient any pain. With leukoplakia, it's a white lesion that can't be scraped off or characterized as anything else. It can appear as a uniform white with smooth or corrugated surface. And tobacco is considered to be the leading cause of leukoplakia in the oral cavity. And it's not always seen with the clinical eye, so biopsy is recommended. Periodontal disease. Those who use tobacco are at increased risk. It is a greater risk than five of the most common bacterial pathogens that cause periodontal disease. So nicotine is a vasoconstrictor, which means it reduces the blood flow to the area. And then smokers have more severe and extensive perio due to the increased pathogenic microisms. So, um, by using tobacco products, it does make the acquired pellicle and biofilm more sticky and it allows bacteria to adhere to the tooth better. So they are going to have more pathogenic microorganisms that cause destruction. Smoking does cause inflammation and it impairs the immune function. So our immune system isn't able to fight off those microorganisms. And that's according to the Surgeon General report of 2014. And even secondhand smoke is linked to periodontal disease. So in oral cancers, one person in the US dies every hour of every day. Half will be alive in 5 years after diagnosis. And there are two distinct pathways. So tobacco, 80%, and alcohol, 70%. And for people who smoke and drink heavily, their risk is as high as 100% more than those who do not smoke, or drink. So if you use tobacco or alcohol, you're at a severe increased risk of developing oral cancers. So you want to check your mouth because by the time of diagnosis, 70% of the cases have already spread to your lymph nodes. And once they've spread to your lymph nodes, then you have a really poor prognosis. And that's why we see here half will be alive in 5 years after the diagnosis. Good news is oral cancer is 80 to 90% curable if it's detected early. So we don't want to have things go for a long time and then spread to the lymph nodes because then, um, it's not as good of a prognosis. So the bad news is that it's usually not detected early, and it does occur more often in men than it does in women. Um, Other cancers have improved their survival rates because of early detection with self-exams. So the medical field and medical industry has done a better job at showing patients how to do self-exams and how to catch cancers early. So as dental professionals, we can be a part of early detection and teach our patients how to do self-exams. We want to let them know that if there's anything in their mouth that hasn't healed within 2 to 3 weeks, that they really need to have it checked because tissues and cells within the oral cavity, they have a high rate of turnover. And so things heal very quickly. And if something's been in their mouth for um, a few weeks to months, then that's something that we should be concerned about. So squamous cell in 90% of oral cancers are squamous cell. It's often only discovered when it's metastasized to another area, like the lymph nodes of the neck. Patients who survive a first encounter have up to 20 times higher risk of developing a second cancer, and this risk can last for 5 to 10 years after the first occurrence. Lip cancer is a sore that doesn't heal, persistent lip pain or lip numbness, a lump or thickening on the lip, white or red patch, and a neck mass. So I do have an experience where I saw a patient in a dental office that had a sore on her lip, and it looked pretty similar to this, except it was on her upper lip. I did not think it was cancer at the time, but I knew that it just didn't seem normal and that it had been there for a while with the patient. And so we gave her a referral to an oral surgeon to have a biopsy. It came back that it was cancer, and she was very grateful that we were able to catch it early. So other oral cancer warning signs is erythroplakia, leukoplakia, a sore throat that does not heal, a lump or thickening of tissue, chronic hoarse throat, difficulty chewing or swallowing, or ear pain. So in this picture here is actually in our clinic, and I was doing EOIO check with a student, and this young man had a lump almost exactly like this, except it was on his left side and it was up by behind his ear. And when we asked him about it, he said that he thought it was because his helmet would rub in that area. And he thinks that it was his helmet that caused this lump. But we explained to him that I think it's because he already had this lump that his helmet was rubbing on it, and I highly encouraged him to go see his doctor. The student said that during the appointment he was concerned about it, so I'm hoping that he did follow up with his doctor, but I haven't heard anything from the student or haven't heard anything about that patient since then, but it was very concerning. I also had another patient that I saw in a dental office where I had seen him about 2 weeks before. He comes back into the office and said that he was just diagnosed with oral cancer. So me and the doctor took him back. We were looking in his throat, looking around. We could not see anything visually. We would not have been able to catch that in the dental office. But the thing that had him go get it checked was he had a sore throat for months that just was not going away. So he went to his doctor, they took an x-ray, and that's how they were able to find the oral cancer in his throat. But it was so far down his throat that we were not able to see it in the dental office. But that's just another warning sign, symptom, anything that's not healing within 2 to 3 weeks, you want to have them follow up with their doctor or with an oral surgeon.
I had my first cigarette at age 13, and at age 17 is when I really started smoking on a regular basis. And then in 2000 is when I found the little sore on the inside of my mouth, and it wouldn't go away. And on a routine dentist appointment, he saw it and he thought it looked suspicious, so he did a biopsy. Well, it came back as mouth cancer. So I had to go through radiation. And then in December is when we discovered the tumor in my larynx. The day of my surgery, I can remember smoking up to the front door of the hospital. That's how addicted I was. And I didn't know that I was so addicted until after I got out of the hospital. When I went home, I went straight. I went straight to my bedroom, picked up a cigarette, put it in my mouth, and lit it. And for the first time, I really looked at myself in a mirror. And I thought, Terry, what are you doing? You have a hole in your neck, and you're getting ready to use. What did it to you? My advice to somebody who doesn't smoke, don't ever start. My advice to those who do smoke, please quit, or at least try.
So, quitting is a process. It's not an event. It's going to take probably a couple of quit attempts before they're successful, just like this lady. I mean, she had just got surgery, and what's the first thing she did? She goes home and lights up a cigarette. That's how addictive they are. So, we want to just be patient with our patients, but also let them know that it's okay if they're not successful on their first time and not to get too discouraged. Otherwise, they will just quit trying and give up. So you can also look at your book for benefits of quitting on box 37.2 for the full list. Um, So both providers and tobacco users must be persistent when it comes to quitting because it is so addictive. Tobacco use independence, it requires repeated intervention and long-term support. So studies suggest that it can take anywhere from 2 to 14 quit attempts before achieving long-term abstinence before they're successful. And so slips and relapses are normal, and we just want to make sure our patients understand that. So tobacco users do want to quit. 70% of tobacco users say they want to quit. 50% try to quit each year, but only 5% are successful without assistance. So healthcare providers can more than double that successful quit rate. We want to give brief interventions, so lasting more than 3 minutes. And then every tobacco user should be offered a brief intervention, even if they're not referred to like a quit line or intensive intervention. So, according to the Surgeon General report of 2020, advice from healthcare professionals to quit smoking has increased since 2000 to 2020. But 4 out of every 9 adult cigarette smokers who saw a healthcare professional did not receive advice to quit. Patients are expecting that when they go into their doctor or their dental professional, they know that they're going to be asked about their tobacco use. And when you don't talk to them about it, then they may assume that it's okay. So as dental professionals, we can take the lead on that, on this issue and try to advise our patients. And interventions from you has more of an impact than family and friends does on your patient. For example, again, 3 out of the 4 of my brothers smoke. I worked in public health in the tobacco office. I know about all the quit lines. I know all the things to help them quit. Will they listen to their big bossy older sister? No, they're not going to listen to me, right? They may hopefully listen to a doctor or dentist or their dental hygienist. Somebody in the healthcare field might have a bigger influence than just shutting me down, who's their sister that they just see as their big bossy older sister, right? So we want to have patient-centered communication. So that's collaborating, not just persuading, right? So we aren't telling them what to do. That just puts their defense mechanisms up. We want to have a conversation with them. We want them to be the ones that want to quit for them. So we want to develop that partnership with them. You want to honor their experience and perspective and stay positive, right? So it has to come from them. Um, when you're eliciting information, you're not imparting information. So, I could sit down with a patient and give them this whole PowerPoint on why tobacco is bad for them. Is that going to change their mind? No, right? They have their own motivation of what works for them, and it must come from them. So it's got to be the patient doing all the talking, not you talking to them or at them. So example of this is my boss had a lady he was talking to that he just asked her, like, what would you do with all that money if you quit? And she said, I would want to take my son to Disneyland. So, so she decided that every time she would have gone to buy cigarettes, she was going to take that money and set it aside. And, there's going to be times that maybe she slips and relapses and she buys that pack of cigarettes. But that doesn't mean that she just gives up. Just the next time she goes and she wants to buy a pack of cigarettes, you just take that money and put it aside. And by the end of the year, she had saved up enough money to take her son to Disneyland. So you just have to find what is motivating for your patient. You want to emphasize clients' autonomy, not expert authority. So again, they are responsible for their change. It's on the patient. Um, and we can't take responsibility for that. We can't say, oh, that patient quit because of me. Like, look what I did, right? Because at the same time, if they aren't successful, are you going to take credit for them not being successful or for them failing? No, because that was on them too, right? So it's on them. You can give them the support that they need, but they are the ones that have to put in the effort. So we have the 5 A's approach to tobacco, and this will be when you get into clinic, your tobacco competency will be on these 5 A's. And you can refer to your table 37.4 and figure 37.6 in your textbook. And so the 5 A's are ask, advise, assess, assist, and arrange. So we're going to talk about these. So your assessment, you're going to um, look at their motivation. Um, their motivation is fundamental to changing behavior. So the client's level of motivation to stop tobacco use is a good predictor of outcome. So how motivated are they? Um, to enhance the motivation to quit, uh, you can ask the clients about their reasons for wanting to stop their tobacco use. You can look at previous quit attempts and asking them about problems they encountered. So this is a good learning example, right? So every time they try to quit, it's not a failure, it's an opportunity to learn what worked and what didn't work. So you can ask them, like, if they said, I was able to quit for 1 month, that's great. What worked for you that you were able to stay quit for that amount of time? And then what was it that triggered you to start using again? Right? So then they know, okay, these are the things that worked for me. And then this was the thing that was a problem for me. And then they can come up with a plan of how to overcome that problem or how to overcome that trigger. So, and then there's also many ways to assess nicotine dependence. We have a questionnaire that you will fill out with the patient that will determine their nicotine dependence level. Um, we want to recommend evidence-based questions to ask the clients to assess patterns of use in their typical day. So clients recall each cigarette, chew, or dip that they had during a day. Um, then, according to the CDC in 2013, approximately 25% of adults in the United States have some form of mental illness or substance use that we talked about, and those adults consume almost 40% of all cigarettes smoked by adults. So, we talked about how mental health is linked to that. So we want to identify those needs, right? And then identify special circumstances that you might need to assess the presence of any contraindications to the FDA approved medications. So, this is where if they are taking any medications, we want them to work with their doctor because, as we talked about before, tobacco can reduce the effectiveness of medications. And if they start to get off the tobacco products, it can change the potency of those medications. So those are things that we have to take into account during our assessment stage. So then setting a quit date, you want to encourage a date within a 2-week period. Clients start to prepare before the selected date, so they want to come up with a plan. Low stress times are better, so they don't want to do it during, the holidays when stress might be high or if they're starting a new job. Um, Select a date of significance that will help them remember the date. So here are some methods to help quit. You can also refer to your textbook, box 37.4. So you have cold turkey, gradual nicotine reduction. So cold turkey is I'm throwing that pack of cigarettes away, never picking up another one. Um, Gradual nicotine reduction would be if I smoke a pack a day, I'm going to now smoke only a half a pack a day for 2 weeks. And then in 2 weeks, I'm going to only smoke 2 cigarettes a day and for 2 weeks. And then I'm going to go down to 1 cigarette a day. Then I'm going to go to 1 cigarette every other day. So you're just gradually, they don't have as high of withdrawal symptoms. Um, Brand switching can sometimes work. If they have a preferred brand, maybe switching to another brand that they don't like as much might make it not as enjoyable, and that might give them the motivation to quit. And then tapering down their use is similar to gradual nicotine reduction. So coping skills. You can see these action responses in your book as well. So you have avoidance, distractions, alternatives, relaxation, use of oral substances, and on the quit date. So during the first 2 weeks of being tobacco free, um, your patient might avoid situations in which they have potential of using tobacco, a high potential of using tobacco products, such as maybe socializing with other tobacco users. Um, since cravings usually disappear after 10 to 20 minutes, teaching clients to focus their attention on doing something else during that time might be able to help them cope with their cravings. Exercise can help with stress and irritability. Taking 10 slow, deep breaths when having cravings can help and allow the few minutes of the cravings to pass. You can help clients make a list of non-tobacco oral substitutes. So sunflower seeds in the shell, so it gives their mouth, something to chew on, gives them that oral fixation. Fruits, raw vegetables, flavored toothpicks, like they have cinnamon flavored toothpicks that might work, xylitol-based candies, something that they can have in their mouth when they have that strong craving for tobacco. You can also encourage them to change their daily routine on the quit date to break away from those tobacco triggers and to decrease that temptation to use tobacco. Then we have coping skills, so your thinking responses. So think positive thinking, delay and rewards. So you can encourage your patient to be as supportive of themselves as they would of, say, their best friend. So we don't want them to get down on themselves. You can encourage your patient to tell themselves, I won't have a cigarette now. I'll decide again in an hour. So just delay it. Be like, okay, right now I'm not going to have it. We'll see how it goes in an hour. And then maybe in that hour they'll still have the willpower to be like, okay, I can do this again. Let me do another hour and just go hour by hour instead of thinking months to months, or weeks to weeks, or even days to days. And then clients are encouraged, or patients are encouraged to choose rewards for themselves every day for the first week. They are tobacco free, rewards themselves on anniversaries to avoid the feeling of deprivation while quitting. And then support from others. So they're encouraged to tell their family and friends and their coworkers, right? So um, when you tell somebody your goals, they can help hold you accountable to them as well. And then if clients are feeling irritable, family and friends will understand more of what's going on, right? So they can help their patients by not offering tobacco. They can provide support and reinforcement so they refrain from tobacco use. They can give patients encouragement if things aren't going well. So when you're open with your family and friends, it's going to make that quit attempt a lot easier for the patient. So, trying to prevent relapse. So, withdrawal symptoms can last anywhere for 2 to 4 weeks. Um, Temptation can last for years. And it is critical for clients to identify at least 3 tough situations that they know they'll be tempted and have a plan for that. Because drinking alcohol is highly associated with relapse, it's often encouraged for patients to review their alcohol use and maybe consider abstaining from alcohol while they're trying to quit. Your follow-up contact. So initial follow-up occurs on the quit date during the first week and within the first month. During the follow-up, you're going to congratulate your patient on his or her success. And if they have experienced a slip, you're going to just transform the event into a learning situation. What worked, what didn't work. So you can help them identify what caused the slip or relapse. to think about what they can do to prevent a recurrence. And then you could even help them set a new quit date if a new quit date needs to be set. And then just keep giving them ongoing support. And then sometimes, like in the dental setting, a referral to a more specialized intensive tobacco cessation program may be what's needed. And that's what we're going to talk about next. So, in public health, the recommended model is AAR, ask, advise, refer. So, in these 3 steps, what you're going to do is ask about their tobacco use, which is on their medical history. You're going to document what kind, how long, and how much they use. There is an ADA code that you can put in the chart. It's D1320. It's not paid out by insurance, but it's just documentation that you did do counseling with the patient. And then you're going to advise the patient on the need to quit. You want to give clear, strong, personalized message, finding out what their motivation is, what's personal to them, and then capitalize on those teaching motion moments with the patient. And then you're going to refer. So you're going to refer the patient to a free quit line. And in Texas, there's a phone number, a fax form, or an app or online portal where you can put in the patient information. So in Texas, it's Texas Tobacco Quit Line. Yes, quit. So any provider can use the referral forms right away without registering with the Texas Tobacco Quit Line. Um, it is evidence-based tobacco cessation treatment services. It can double as individuals' chances. It can double the individual's chances of quitting. It is free and confidential, and it's available 24/7 to Texas residents 13 years of age or older. It does come in over 100 languages, and their counselors get over 200 hours of training. They know they are specialists in helping people quit. Okay. For the nicotine replacement therapy, it, um, they do deliver the products to their home. It includes the patch, gum, or lozenge to anybody who's enrolled with the coaching program. Um, They do provide up to a 2-week supply of the nicotine replacement therapy to anyone 18 years old or above. And the quit line does treat teens who want to quit vaping. So any youth 13 to 17 years of age are permitted to participate in the tobacco cessation counseling quit services without parental consent. Um, and they're always staying up to date on any changes in the laws or regulations that might prohibit youth from participating in those quit services. So when you refer, the first step is to make sure they're ready to quit within 30 days. Okay, if they're not ready to quit within 30 days, we don't want to give them a referral yet. We just want to keep counseling them or advising them whenever they come into the dental office, and then when they are ready is when we can send that referral. Where I'm going to show you the referral tools on the next page, but they do have an app or an online portal or fax form. And when you send the patient information to the quit line, they will then contact the patient and get them set up on the program. So there's nothing else that you need to do. You just send them the information. So here is the different referral tools. You have the quit line fax form. You have the online portal where you just click here and you fill out your information and the patient information. And then they do have a Texas Quitline app, so you can just get it on your phone. And it's similar to the online referral system where you just fill out the patient information and hit submit, and then the Quitline will contact the patient. There are 7 FDA approved quit tobacco medications. So you need a prescription for the nicotine inhaler, which is kind of similar to, say, like um, an asthma inhaler, except it's going to look like a tube, kind of like a cigarette. So it's going to have that hand to mouth action, but the medication inside would be similar to an asthma inhaler. The nicotine nasal spray, they just spray into their nose. Then you have Chantix, which is a pill, and how it works is it blocks the nicotine receptors, so that if they're using tobacco products, they're not getting that high, because those receptors are blocked. And then Zyban is also called bupropion, which is an antidepressant. And then the over-the-counter and also what you get from the Quint line is either the nicotine gum patch or lozenge. So how you want to use these is for the nicotine gum, what they're going to do is they're just going to chew it until it gets like a peppery taste. Then they're just going to park it in their cheek. And then the nicotine will absorb through the gum tissue. And then when you need more, you just chew the gum enough until you get that peppery taste, and then again, park it. So if you continuously chew it, you're continuously releasing that nicotine. And if you swallow it, it can make your stomach feel nauseous. Um, this is the same with the lozenge. You're just going to park it in your cheek and let it dissolve on its own. Okay, if you chew it and swallow it, it's going to give you too much nicotine. You're going to feel really sick. And then for the nicotine patch, they'll put the patch on in the morning and then they need to remember to take the patch off before they go to bed because it is giving them a constant dose of nicotine. It will keep them up at night. Okay. They will not sleep well if they keep the patch on 24/7. So they do need to remove it before a couple hours before they go to bed. So they're not getting that nicotine spike all day long. All right, so nicotine dependent patients, they usually do need pharmacological support to help their quitting process. So how much support they need depends on the patient and their behavior and what other medications they might be on. Also, what drives the tobacco cessation care plan. So a hygienist may recommend over-the-counter nicotine replacement therapies and other FDA adjuncts. The patient does need to be cautioned that no medications are a magic bullet. And so it's going to take medications along with other behavioral changes that they'll make. So the purpose of the nicotine replacement therapy is just to provide some blood concentration of nicotine to help reduce or eliminate withdrawal symptoms so that the patient can focus on their behavioral changes to stop their tobacco use. Sometimes those withdrawal symptoms are so severe that the patient just gives up and they can't continue their quit attempt. So this just helps to take that edge off so that they can continue their quit attempt. Um, let's see. Yeah, so in general, nicotine replacement products are contraindicated for patients with underlying cardiovascular disease, especially those who have had recent myocardial infarction, life-threatening anemias, or severe worsening angina. And so you do want to refer to your book on table 37.6 and figure 37.10 for more information on that. But this is how the plasma nicotine concentrations look. So if you look at that green line, that is the spike in nicotine that you get from taking a puff on your cigarette. Okay, so it's a pretty rapid increase of nicotine, and then it's a pretty rapid fall. With the moist snuff, which is like chewing tobacco, it's not as rapid of an increase and it doesn't get quite the spike it does as a cigarette, but it gets pretty close. And then the other ones that we see here at the bottom, those are your nicotine replacement therapies. So it's giving you just a little boost of nicotine over extended period of time. It's not these huge spikes and falls. It's just kind of gradual and staying there at the same. Um, and so it just helps to take the edge off of those withdrawal symptoms, just giving them enough nicotine so that they can make it through and be successful on their quit attempt. So, what do you do if a client is not ready to quit? You want to, you can look at your table in 37.5 in your textbook, but so you want to still give them a brief intervention, communicate that acceptance of the patient's decision not to quit at this time. You cannot convince somebody to quit. Okay, so do not argue with them. Do not try to convince them. Don't try to give them all the statistics and stats of why it's bad for them. Like it is their choice. They have to be the ones to make that choice to quit, and there's nothing you can do or say to change that. But if you are supportive of them, then they will trust you. And so the next time that they come in, they might be more willing to listen to you, knowing that you are supportive and not judging them. Okay, so it's about building that relationship with the patient. For motivational interviewing, you want to show empathy to accept without judging, criticizing, or blaming. We don't want to do that at all on anything that we talk to our patients about. Not about quitting tobacco, not about flossing, not about brushing. Like, we just need to show empathy for patients, and they will start to trust you, and then they will listen to you later. They're not going to just trust you right off the bat. You have to earn their trust. So change is motivated by their personal goals or values. So you have to find out what's important to them. Resistance is acknowledged, avoid arguing, and enhance the patient's confidence in their ability to cope with obstacles. So they may just feel like they're not capable of quitting. They may not have the confidence in themselves. So we want to try and help give them that confidence if we can. So here's some things that you can do for tool for change or ORS. So open-ended questions. Affirming change talk, reflective responding, and summarizing results of dialogue. So, open-ended questions during the motivational interview. You allow the person to express him or herself and explore both sides of the patient's ambivalence about tobacco use by asking open-ended questions. For example, what do you like about tobacco use? What kind of roadblocks come to mind when you think about stopping quitting? Those are some of the questions that you could ask that are open-ended that will help you understand where they're coming from. Affirming change talk. So this strategy reinforces and focuses on patient comments that support stopping tobacco use. So for example, say, that's a good point. Do you have any other concerns? Reflective responding. This is a technique that acknowledges to the patient that he or she is heard. So, for example, you could say, so one of the most important considerations for you is how your smoking may affect your daughter. So you're just stating back to them what they said to you, and then summarizing results of the dialogue. Doing this, it brings closure to the session. So, for example, you might say, so if I understand you so far, you enjoy smoking because it relaxes you, but you have some real concerns that it is beginning to affect your health and that you may be a negative role model for your daughter. It is clear that you have overcome a number of challenges in your life. I have confidence that you'll be able to resolve this issue of smoking once you make up your mind. If it's all right with you, I'd like to check in with you at your next appointment to see where you are in your thinking about all of this. Just know that if you decide to try to stop smoking, we can help. So you just summarize everything that you talked about and then leave them with positivity and that we're here to help them. All right, so implementing a tobacco intervention program in your office. So dental hygienists are often the strongest proponents of tobacco intervention activities because we do most, if not all, of the education for patients. We spend more time with them, right? So you want to generate team support. You want to have a designated coordinator, create a tobacco-free environment, and address reimbursement issues, which most insurance do not reimburse for tobacco intervention. So your role in the community, you can refer to your textbook in box 37.7. So you want to endorse tobacco intervention policies, ensure that continuing education related to tobacco issues is on the agenda for professional conferences. I know some states like Arizona, it is a requirement to do tobacco cessation CEs with your licensure. Just kind of how like Texas has you do human trafficking. That's a requirement. That's one of the requirements in Arizona and other states. You want to reinforce peer awareness of key tobacco information, volunteer support for tobacco-related events, support a tobacco-free society, advocate for tobacco-free children, lobby for tobacco-free environments, and provide education to children, sports teams, PTAs, etc. on tobacco. And then here are my references. And if you have any other questions, you can always reach out to me.